Hello, my name is Angela Henley, and I am a student at Georgia Southwestern State University in Americas. My teacher is Miss Gee, and this is my research presentation for the research class. I'm an RN BSN student, and this is PICC line versus central lines. I hope you enjoy the presentation. How to reduce catheter-related bloodstream infections. This research paper seeks to answer the question, in adults aged 20 years and older, does having a PICC line compared to other types of central lines have less infection rate during the first 2 months? Typically, if you go into the hospital, you're going to end up with an IV access of some type, either to receive blood or medications or IV fluids. And every time that you are stuck for an IV access, there is a chance of infection. And we want to find out if a PICC line can have a less chance of infection for the patient. Some organizations have a higher rate of infection with other forms of central lines versus the PICC line. Therefore, some organizations plan to reduce the amount of lines that are placed by doctors and increase the amount of PICC lines inserted by the PICC team nurses. Hospitals have decided to extend the PICC team as a method to reduce infection rates from central lines in their facility. Is there enough evidence that will support the increased use of PICC line insertions? The databases that were included in the study, PubMed and Biomed. You will see the systematic electronic literature search included many common databases up to February 2012. There was an extensive electronic search that included Biomed Central all the way through Google Scholar and Science Direct. There were specific terms that was included in the search, such as you will see peripherally inserted central catheter, central venous catheter lines, CVC infection rate. The selection criteria was English publication within the past 5 years. Articles that were considered suitable for inclusion discussed catheter-related CVC and or PICC bloodstream infection. Any article before the year 2011 was excluded. This is the 5 that was chosen. Number 1 was 2012, and there was 9,724 population size. The age was from 47 to 65. The second one was to the year 2012. It was a comparative study that had 3,116 lines, and adult patients were considered for inclusion. The third one was 2015, a retrospective study, had 371 patients 18 years old and older. The fourth study was 2013, a prospective study only, and it included a total of 423 lines, 28 days to 28 years of age. The people that was under 18 years of age were not included. The fourth study was 2012, a retrospective study, population size 89 lines, 65 adults and 24 children. The children were excluded. We will talk about the results a little later. Morbidity and Mortality Weekly Report 2005 acknowledged healthcare associated infections in U.S. hospitals account for an estimated 2 million infections and 90,000 deaths annually. Central line associated BSIs are the third most common healthcare associated infections. MMWR reports that CDC has identified catheter associated adverse events, including infections, as one of its 7th healthcare safety challenges, with a goal to reduce such complications by 50% in 5 years. The change that will improve the incidence of lower central line infection rates in the hospital setting would be for the PICC team nurse to place as many central lines as possible versus the doctor. The PICC team is a small group of trained nurses that would place the PICC lines, change the dressings, and monitor for infection. The practice of using a smaller group of trained professionals to place the PICC lines would reduce the infection rate because there would be less individuals placing the central lines and therefore less possibility of infection. The following are the recommended guidelines that must be followed in order to reduce catheter-related bloodstream infections. Protocol to improve nursing practice and patient care. The nurse must assess if the patient is in need of a central line and recommend to the doctor that the PICC team be consulted. The PICC team personnel must be trained and exhibit competency in the insertion of catheters. And then there was a list of 13 things: good hygiene, maximum sterile barrier precautions such as cap, mask, gown, sterile gloves, sterile gown, large sterile drape during the insertion, preparation of central venous sites with a special cleaning gluconate, use of a biopatch, transparent dressings, sutureless securement device such as a stat lock. That's what's used at the hospital that I'm associated with. The PICC catheters can be coated or impregnated with an antimicrobial or antiseptic agent. Use the PICC with a minimum number of ports or lumens essential for the management of the patient. There's a single, a double, and a triple lumen port at the hospital where I'm employed. Replace the catheter site dressing when it becomes damp, loosened, or soiled, or when the inspection of the site is necessary, and at least every 7 days, and 2 days for a gauze dressing. Do not routinely replace central venous catheters to prevent infection. Remove any intravascular catheter as soon as it is no longer required for patient care. This is a concluded study that the economic burden of infection is substantial. Estimated that each CLABSI episode independently increases length of hospitalization from 7 to 21 days and adds an attributable cost of about $37,000. That was 2002 dollar amounts per patient. The annual national cost for patients who develop an infection is estimated to range from $0.67 to $2.68 billion. Given this clinical and economic cost, investigators, policymakers, and regulatory agencies in the U.S. and abroad have devoted great efforts to curtail claspius over the past decade. Chopra and al. Have reported data from several studies suggest that CVC placement by specialized teams dedicated to this role leads not only to greater placement skills and reduced insertion complication, but also to reduced rates of institutional claspia. The hospital, the insurance company, and the patient would benefit from the PICCs being inserted by the PICC team nurses, which would prevent infection, extra medical costs, and extended hospital length of stay. The CDC and the Joint Commission on Accreditation of Healthcare Organizations, JCAHO, would benefit when the rate of catheter-associated infections are reduced. The patient and the family would benefit greatly if the prevented infections were reduced or eliminated, reducing mortality. The first study up there argued that PICCs are also usually considered a device at low risk for catheter-related bloodstream infection, which may be an additional advantage to acutely ill patients. Also reported in a surgical ICU, PICCs presented 2.2 episodes of infection per 1,000 catheter days versus 6 episodes with CVCs. And then another study, there was only 1 episode of infections in a cohort of 50 PICCs consecutively inserted in ICU patients. In another study, there appeared to be happening with infection compared to PICCs with a later occurrence, 23 days versus 13 days. So the longer the line stayed in, the greater the chance of infection. 4 in a burn unit, 37 PICCs had the incidence of PICC-related bloodstream infections was 0, as compared with 6.6 episodes of CVC-related bloodstream infections for 1,000 catheter days. PICC and all declared that their only comparative study found that PICCs 2.7 was associated with fewer CRBSIs than CVCs, 4.9%. Nolan and all found that only 1 single PICC infection in 400 central lines evaluated, making their MICU Pacific rates generally lower than reported in other ICU settings. John Nason et al. Reported they claimed that PICC lines have fewer complications than other kinds of infections. UGAS and all found that PICCs were associated with fewer infections than CVCs in long-stay patients in surgical intensive care units. Evidence supports that the use of PICC lines versus other CVC lines reduce infection and reduce mortality rate. Therefore, the recommendation that more PICCs be inserted is favorable to become common practice in hospitals across the nation. Thank you for your time. I hope you enjoyed this research presentation, and I hope that you learned some valuable information, and I hope that you will become someone that will agree that PICC lines need to be inserted to help reduce infection rate, to reduce mortality rate, and to reduce extra costs for you, your loved one, our hospitals, our organizations, and our government. Thank you.